morning, everybody. My name is Parul Ichhpujani. I'm ophthalmology faculty at the Government Medical College, Chandigarh. I have recorded previous lectures with the DigiNEET, and I hope some of you have enrolled in that platform and have, taken or learned some lessons from it. I thought of this topic because there are lots of tests which are there in each chapter. And many times we overlook the basic tests or we don't read in between the lines when it comes to the diagnostic tests, because we are so focused on the particular named signs or on the main topics that diagnostics test, they take a backseat. But as you will see during the course of this lecture, that it's very important to read or be aware about these tests because several questions can be formulated from them. Before I begin, we have a very windy situation outside. So in between, the electricity can go and I might take 5 minutes to join on my telephone's hotspot. Bear with me if that happens. Having said that, let's begin this interesting topic of diagnostic tests in ophthalmology. So we'll be talking about various diagnostic tests in ophthalmology. So you all know that when you go for your clinical posting, the first point at which the patients are greeted in an ophthalmology OPD is when their vision is checked. So the vision is checked using this chart, which is called as the Snellen's visual acuity chart. Now, it's important for you to know that all these alphabets or letters or numbers that are written in these charts are called as optotypes, and they're arranged in decreasing order of size. The standard visual acuity testing distance is 6 meters, or if you convert it into feet, it becomes 20 feet. And visual acuity is commonly recorded as a fraction, 6 being the perfect vision. And then as we go further, it reduces. So 6, 6, 6, 12, 6, each lesser than its predecessor. So 6, when we say, it means that this person can read at 6 meters what a normal eye sees at 6 meters. 6, 12 would mean this person can read at 6 meters what a normal eye would have read at 12 meters. Now, everybody is not literate to read out these alphabets. So for illiterate patients, there are other charts such as tumbling E chart, in which the direction of open arm of the E is asked from the patient. Or we have the Landolt C chart, in which the direction of cut end of the C is asked from the patient. Then we have modern charts like logmar charts, which are more accurate and especially used in research. So the logmar charts commonly used are the ETDRS chart, which has 5 letters in each row, and the difference between each row is also standard, that is 0.1 log. This is a gold standard chart. So if you're given a question as to which is the gold standard chart for assessing visual acuity, your answer should be the ETDRS chart. Now, this chart has something which is called as Sloan letters. Sloan letters are perfectly square, approximately equally legible one from the other. So this alphabet is in a perfect square. Similar chart, which is a logmar chart again, is a Bailey-Love chart, which has rectangular letters in the ratio of 5:4, and it's based on a transport typeface. So it's important for you to remember that logmar charts are of 2 types, ETDRS and Bailey-Love. The ETDRS is the gold standard and it has Sloan letters. 5 letters in each row. The difference between each row is 0.1 log. So this you remember, as this can come as a question. So keeping this as our base, if we encounter an MCQ where it says that in logmar visual acuity scoring, a lower score indicates worse visual acuity, better visual acuity, no change in acuity, or color blindness. Now, it's very obvious that color blindness is out of question. No change in acuity is also out of question, because when we are talking of a lower score, it's understood that lower and higher would mean something different. At that point, just remember this, 20/20 is equivalent to 0 in logmar, and 2200 is equivalent to 1 in logmar. So definitely a lower score indicates better visual acuity. Now, that was about the distance visual acuity. When we talk of near vision, as we get older and we cross 40 years, we are not able to read the near words, and that's called as presbyopia. So it's important to check near vision. There are three types of commonly used near vision charts. One involves the Snellen near vision chart. This you have to remember. The distance visual acuity chart is reduced to 1 by 17th of its original choice. So 1 by 17th can come as an MCQ. There are other charts like Jaeger charts, which is read at a distance of 14 inches, and the notations are J1, J2, or J3. J1 being good vision. Roman test types are also there, which is very commonly used. It uses Times New Roman, and you have to read out these paragraphs. If you are able to read out the smallest alphabet, then the perfect near vision is called as N6. Otherwise, it just goes on increasing. So our target is to add a lens correction, which makes us read N6. Another question related to visual acuity assessment can be using a pinhole. So once we check uncorrected visual acuity, we put a pinhole in front of the eye. There is a smaller blur circle which is formed on the retina. So the pinhole test is used to differentiate refractive errors from pathological causes. So if the vision improves using pinhole, that means there is a refractive error. If the vision reduces during pinhole, that means there is a macular pathology, because the light is forming specifically now at the macula since the peripheral rays are cut out. So if using a pinhole it deteriorates, that means there is a macular pathology. What is the minimum visual acuity which is required to drive legally in most countries without a glass correction? Is it 6 by 60, 6 by 18, 6 by 6, or 6 by 36? It's great if you have 6/6 vision, but the minimum cutoff is 6 by 18. Anything less than 6/18 and you are not wearing glasses, that is absolutely unacceptable and is likely to be fined for this. Now, the next question is, if there is a patient and he's unable to read beyond the 660 line, that is the topmost big alphabet on the Snellen chart, what is the next appropriate step in assessing visual acuity? Will you use a Jaeger chart? Now, already I'm not satisfied with this distance vision assessment. Why will I use a Jaeger chart straight away? Jaeger chart is a near vision chart. I want to do something more with the distance vision assessment. Will you use an Ishihara plate? No. We will do testing using counting fingers. We will go up to a distance of 5 meters and see if the patient can see. So we will say that now the visual acuity is 5 by 60 or counting finger 5 meters. Or if the patient is not able to read even at 5 meters, we will go to 4 meters, 3 meters, 2 meters, 1 meter. And eventually we will count fingers close to the face, or we will try moving our hand and see if the patient can perceive hand motions. And if the patient cannot even do that, we will shine a bright torchlight in their eye and see if they can perceive the light. So C is the correct answer. Will we do tonometry? No, tonometry is an assessment of the intraocular pressure. So the correct way to go is to first complete distance vision assessment. After that, put a pinhole in front of the eye and see if the vision is improving further or not. And then once the patient is sent for refraction, during refraction, once you have corrected the distance visual acuity, then we check these near vision using a Jaeger chart or a Roman test type, and then we prescribe the near vision add. Then the patient is sent for clinical examination, and based upon the clinical examination, if tonometry is required or Ishihara plates are needed, those tests are done. So coming to color vision, why do we need to test color vision? Now, many of us are born with congenital color vision deficiency. We are not able to differentiate between red and green. For us, if we are red or green colorblind, red would mean something different than what a color abled person would be able to perceive. So they have their own red, they have their own green. Also, it's important to recognize acquired color vision deficiency. So there are several medications which result in an acquired disorder, and these medications need to be discontinued if somebody develops this disorder. Once you have diagnosed a color vision deficiency, it's important to grade it in terms of its severity. And this is very important not only for diagnostic purposes if somebody is on certain medications, but it's also very important for certain professions. For example, it's very important for a locomotor train driver to see red and green, the signals properly. Similarly, for aviators also, it's very important. For doctors, for surgeons especially, you have to be able to differentiate between blood and bile. So there are certain branches where color vision differentiation becomes really, really important. So for vocation or occupational purposes, it's also important to know color vision. Now, there are several types of color vision tests, and you can be asked about which test befits which group of color vision assessment tools. So one, we have pseudo-isochromatic test, in which, you would have seen in your ophthalmology postings that there is a booklet with colored numbers on it, and that's the Ishihara test book. It is used for red-green deficiency. It has 38 plates. It's the most commonly used book. Then it's important for you to remember two more books, that is the Hardy-Rand-Rittler or American Optical Hardy-Rand-Rittler. These have the additional advantage of being able to detect blue and yellow defects. Now remember, blue and yellow defects are usually acquired defects. So Ishihara's, unfortunately, is not able to check blue and yellow. So if you have to look for blue and yellow, you need either Hardy-Rand-Rittler or American Optical Hardy-Rand-Rittler. Then we have certain tests in which you have, a panel of similar colors, some lighter or some darker than other. So there are different hues of the same color, and you have to arrange them in a single order. So we have Farnsworth D15 test, in which you have 15 colored caps, which are to be arranged by hue of increasing tone of that color. This is used to detect mild to moderate defects. Farnsworth-Munsell 100 hue test has 85 caps. This is a very highly sensitive cap, and it is used for research and occupational screening. So it's easy sometimes to, align 15 caps, but you have to be very precise when you're aligning 85 caps. So Farnsworth-Munsell 100 hue test is more sensitive than the D15 test. Lanthony desaturated D15 is similar to the Farnsworth D15, but here they're making use of lighter shades. This is better at detecting the acquired defects. This is how the Ishihara pseudo-isochromatic plate looks like. So you can see a number. There are green dots of similar shades of green on a background of red with different sized and different colored dots of red color. And this just pops out the number. It is made in such a way. This is a very standard testing book. There are 38 plates in it. The first plate is a demonstration plate, number 12 usually. This can be seen by everybody, even by the colorblind person. So if somebody says that they cannot read plate number 1, that means they are malingering, they are lying. Plate number 2 to 9 are called as the transformation plates. They have what I, as a normal person, will read as 29, but a colorblind person will read it as a different number. So these numbers can be read even by colorblind people, but different than what a normal person would read. Now, plates number 10 to 17 are called as vanishing plates. These are seen by normal trichromats. These are seen by only us who can read the colors, but not by the color vision patients, color vision deficient patients. Plates number 18 to 21 are called as hidden digits. Now, people who are normal cannot read any digit in such plates, but somebody who has color vision deficiency will be able to pick out a number in this. Then we have plate number 22 to 25, which are called as the diagnostic plates. These are seen by normal people, and they help to differentiate protons and deuterons between red prominent or green prominent color deficiencies. And then we have in the last plates number 26 to 38, which are tracing plates where you have to trace the red in this sea of green colors. These are used by patients who are unable to read numbers. So the two important things you have to remember, which can come as an MCQ, is that distance of keeping the pseudo-isochromatic plate is 75 centimeters and the test duration per plate is 3 to 5 seconds. So this is how record is maintained. This is the plate number. This is how the plate is perceived by trichromats. This is what the plate would be perceived by a protenope or a deuteranope. And this is what plate would be perceived by a monochromate. Then we have certain other tests like anomaloscopes. We have the most commonly used anomaloscope is Nagel anomaloscope. It's the gold standard for diagnosing red-green. The patient matches yellow with the red-green mix and it quantifies severity. So the gold standard is Nagel anomaloscope. That's what you need to remember. For occupational screening, as I did talk about aviators or the train drivers, there we can use the Edgar Green-Lantern test or the Martin-Lantern test. So these are these important occupational screening tests. So now you can get a question that a person with protanopia has difficulty in distinguishing which two colors, blue and yellow, red and green, black and white, or orange and purple. So very clearly, the last two options are out of the kitty. We are going to be talking about blue and yellow and red and green essentially when we talk about color vision deficiency. So which out of these two needs to be the answer? So we have repeatedly been talking about protanopia and deuteranopia. So the answer is red and green. Tritanopia is deficiency of the blue part of the color. So protanopia is essentially red blind. Affected cones are L cones. And remember, it is mostly seen in males and has X-linked inheritance. Deuteranopia is green blindness. M cones, which are medium-sized cones, are involved. This too is X-linked and mostly seen in males. Tritanopia, on the other hand, is blue blindness. The affected cones are S cones, and it is an autosomal disorder, and both the genders are equally involved, and it's quite rare as compared to its red and green counterparts. What is the total absence of color vision known as? Deuteranopia, dichromacy, monochromacy, or tritanopia. Now we know the first two options are involving another color. So since there is a color deficiency involved in the first two and the last option, the correct answer is C, monochromacy or achromatopsia. Now, color vision deficiency is associated with central serous retinopathy. Central serous retinopathy is a disorder of retina in which there is a fluid buildup just underneath the macula, and this results in which type of color vision deficiency? Now, you know this is not a congenital disorder. It's an acquired entity. Since it's an acquired entity, we know that it is the blue-yellow deficiency that is common in acquired disorders. Therefore, the correct answer is B, that is the blue-yellow deficiency. Unlike the Ishihara test, the HRR test can detect only red-green defects, only blue-yellow defects, both red-green and blue-yellow defects, or the visual field defects. As we have already talked about, the Hardy-Rand-Rittler or the AOHRR, American Optical Hardy-Rand-Rittler, these are both these tests that can recognize red, green as well as blue, yellow defects. So the correct answer here is C. And this is how the Hardy-Rand-Rittler color plate looks like. Next comes another concept which is very important, that is contrast sensitivity. Now, if you would have taken the history of a cataract patient, or if you would have seen a glaucoma patient in your ophthalmology posting, you would have heard from many people that it is very difficult for them to adjust when they come from a bright light into a room or when they move from a room into bright sunlight. So this adjustment requires the element of contrast sensitivity, which is a very important visual function. And if contrast sensitivity is impaired, as is seen in several disorders like cataract, like glaucoma, or age-related macular degeneration, then that means that the disease is progressing. So we need to also monitor contrast sensitivity, note down the value of contrast, and see if it is deteriorating and address the issues accordingly. Remember, visual function is not just visual acuity. It is a combination of visual acuity, color vision, contrast sensitivity, our visual field. So all these components come together to formulate visual function. Now, why do we need to know contrast sensitivity? This is a very important function in our day-to-day life. Now, if you're walking on the road, the corner of the footpath or the pavement and the road, which are pretty much gray in color, but different shades of gray, if you don't have a good contrast sensitivity, you will not be able to differentiate this. If you're driving at night, if your contrast sensitivity is poor, you will not be able to ascertain if something just comes into your field of view suddenly when you are driving. So it's very important as a real world visual function. If you see the Snellen's visual acuity chart, there is a stark black letter which is written on the white background. In real life scenarios, contrasts are not this black and white. There are more shades of gray in contrast. So life is not as stark as Snellen's. So for day-to-day activities, for elderly people, it is very important to be able to differentiate. If they're going down the steps, if they are not able to differentiate border of one stair from the other, they will have a fall. So cataract patients, glaucoma patients, age-related macular degeneration patients, when their disease is progressing, contrast goes on falling down further. So it's important to document this test. So the most commonly used test in clinics is Pelley-Robson chart. This is how the chart looks like. There are several alphabets, but as you can see, as we are going down the chart, they are fading. So they are going into gray and eventually fading. So these contain letters of same size but decreasing contrast. Patient reads this from left to right, and the contrast reduces after every 3 letters. The testing distance for this test is 1 meter. If here you get a value, less value means severely impaired, more value means good contrast. So 2 or 2.3 would mean excellent contrast sensitivity, while 1 or less than 1 would mean an impaired contrast sensitivity. Another tool which is used for checking contrast sensitivity is CSV 1000 test. You can see here also there are different types of circles with different lines of different sine wave gratings in different panels. So here we are checking low, medium, and high spatial frequencies. This is more used for research and if you're going too much into detail of a clinical evaluation. So it checks 4 types of spatial frequencies, 3, 6, and 12 to and 18 cycles per degree. So you get a question that a patient complains of poor vision in dim lighting despite having 6/6 vision. What test is most appropriate? Now, dim lighting is the clue here, which will tell you that you need to check the contrast. Color vision testing a person would be color vision deficient in both dim or bright lighting. So the lighting would not be the clue here. Visual field testing would talk about restriction of field or development of a scotoma. So this also is not the correct answer. An applanation tonometry would have some cue about glaucoma or raised pressure. So here, therefore, by exclusion, the correct answer is C. That is contrast sensitivity test. So contrast sensitivity test is most critical for which of the following tasks? So here you see this gentleman who's driving in the night and there is yet another passerby on the road. So everything is looking gray, but in a different shade of gray. So contrast sensitivity is most critical for reading an eye chart in a clinic? No, because the contrast in the world and the background is quite stark. Identifying colors, for that we have color vision. Night driving and low light navigation, I think this is the correct answer as we can see here. and reading bold headlines. Now, when the headlines are bold, they are standing prominent against a background, this cannot be the right answer. So the correct answer is night driving and low light navigation. The functional difference between Snellen equity and contrast sensitivity is that Snellen measures low contrast only. Not at all. We have seen that we have dark black letters on a light background. How can it be checking low contrast only? So Snellen's actually measures high contrast. Snellen is used only in children, not at all. Snellen is used by children, by adults, by literates and illiterates, everybody alike. Contrast sensitivity evaluates performance under realistic visual conditions. So this is what we have reiterated in the previous question also, and therefore this is the correct answer. The fourth option was Snellen uses color targets. No, Snellen uses black targets against a white background. So fourth option also is incorrect. The next question which can come is which spatial frequency range is most affected in early contrast sensitivity loss. So always remember, whenever there is an early loss, it is the high spatial frequency which goes, followed by medium spatial frequency, and then eventually by low spatial frequency. So even till later parts of the disease, low spatial frequency is preserved. Then comes the most important testing that we do after we have examined a patient on a slit lamp, the anterior segment. After that, we need to see the retina. And retina can be examined using several instruments. And one of the most common instruments for retinal examination is direct ophthalmoscope, which can be used even bedside. Here we have Dr. Talveer Sidhu. She is my teacher in the DigiNEET course, and Dr. Sidhu has recorded these videos, and she is doing direct ophthalmoscopy here on a patient. Direct ophthalmoscopes gives us a direct and virtual image, which is 15 times magnified in e-metropes. This is good for bedside examination, but you cannot get a 3D image. So the depth perception is compromised with this. This ophthalmoscope can also be used for distant direct ophthalmoscopy. What do you mean by distant direct ophthalmoscopy? Is that you can assess whether the glow of a dilated fundus is good. So if the glow is good, that means there are no media opacities. Here you can see that when you shine it, there is a bright orange reflex which is coming, and that means that there is no cataract, there is no vitreous hemorrhage, there is no corneal opacity. So using this DO, we can also do distant direct ophthalmoscopy. Now, this direct ophthalmoscope has apertures of several sizes. It's important for you to know that dilated pupils are seen by the large aperture. The small or reactive pupils are seen using the small aperture. And if you're looking at the vascular details, or if you want to look at the retinal nerve fiber layer, then we need to use a red-green filter. So here we have a wheel. We can move the wheel, and then there is a red-green filter, which will help us to assess the vessel integrity or detect hemorrhages or retinal nerve fiber layer defects properly. For depth assessment, again, using this wheel, we can make a small slit beam, and we can see if there is any retinal elevation. For a larger view, for looking at the retinal periphery, if you are looking for any degenerative changes in the retinal periphery, we need to use an indirect ophthalmoscope. This is how it looks like. There is a headband, and there are several apertures, a red-free one, a cobalt blue filter, and then there is an integrated one. You can adjust this instrument for pupil size, and then there is an illumination beam. This, unlike its direct ophthalmoscope counterpart, gives you a real and inverted image. And that too, the size depends upon the condensing lens you are using. So you wear this indirect ophthalmoscope as on your forehead, and then you use a condensing lens in between yourself and the patient's eye. So this lens can be either a 20D or a 28D. A 20D will give a magnification of about 3 times, and the field of view is about 40.8 degrees. On the contrary, 28D would give a magnification for 2.27 times, and the field of view is more about 53 degrees. So usually in our clinical practice, we use 20 diopters. Just remember that sometimes when you're looking at extreme periphery, you have to do scleral indentation. You have to indent the sclera so that the extreme peripheral view also becomes visible. Scleral indentation can be done either using a bud or it can be done using a special instrument called as a scleral depressor. Now, this is again Dr. Talveer Sidhu doing an indirect ophthalmoscopy, and you can see she is wearing the indirect ophthalmoscope, adjusting the light, using the different apertures or on the device. And once you are satisfied and you know that the light is properly centered and focused, you take the condensing lens and place the condensing lens between yourself and the patient. This is the condensing lens. And in a dilated patient, now she's just trying to focus again. This is bright and yellow light. And you put the lens in between the patient's eye and the instrument and see the fundus. That's the condensing lens. The findings that you see are recorded on a cartogram or on a chart which is called as the Amsler's-Dubois retinal chart. So there are certain codes which we use for different colors for different findings, and that's how the findings are recorded. So you can get a question that indirect ophthalmoscopy is preferred when only the central retina needs to be examined. It's a portable method is required. A wider field of view and peripheral retina examination are needed, and color vision is being needed. So for central retina, doing a slit lamp examination with a 90 diopter lens is good enough. It is portable, but the most important feature of indirect ophthalmoscope is that it is used when we require a wide field of view, when we are looking at the periphery, when we want to look at a peripheral retinal degenerative lesion. Like in high myopes, there can be retinal holes, there can be retinal breaks. So the correct answer is C. This is slit lamp biomicroscopy. This is how a slit lamp looks like. And here we use a 90 diopter lens and we look at the optic disc and the retina. So here we make a small slit beam, and using a 90D lens, this is what we see on the slit lamp. So here you can see that the patient is sitting on the slit lamp, and we are adjusting and aligning our instrument and checking using a 90 diopter lens. It's very important to align the magnification of the lens when we are examining. So a thin slit beam is formed and the examination is carried out. So this is the 90D lens. This is how the fundus looks like. That's the optic disc. These are the primary blood vessels. Here we have the cup. Increase in cupping is suggestive of glaucoma, as you would have read in other things. So this is a fundus photography camera. We can record the fundus photographs and eventually over a period of time match these photographs to see if the disease is progressing or not. So this is a fundus photography system. We can also have a handheld fundus camera, as you can see here, or we can use smartphones these days and add on condensing lenses in front of smartphones and take a picture. This is very relevant when it comes to screening. So for large scale screening for diabetic retinopathy or for glaucoma, when camps go, or if there is an opportunistic screening being done in the community, these tools come in handy. So the question that can come is, which wavelength of light is typically used in conventional fundus photography? Infrared, ultraviolet, visible white light, or X-rays? The correct answer is visible white light. Then building upon fundus photography is yet another important test, which is called as the fundus fluorescein angiography. Now in this, we inject a dye in the antecubital vein. The dye which is used is the sodium fluorescein dye. About 5 ml of 10% of this dye is injected. This dye circulates from the arm to the retina, and it circulates within 8 to 15 seconds from arm to the retina. Now, the fundus camera has built-in filters which help us to capture the images. There are two types of filters. One is the blue light filter, which is the excitation filter, of the wavelength 490 nanometers. And then we have a barrier filter, which is 520 nanometers. Now, why we need to do fundus fluorescein angiographies to detect certain retinal and choroidal disorders, and the common ones out of those are diabetic retinopathy, age-related macular degeneration, retinal vein occlusion, macular edema, or choroidal neovascularization. So it's important to know what are the phases and what would you see in these phases. So first is the pre-arterial phase or the choroidal phase. So from arm, once the dye has reached the retina, it first enters the choroid. The timing after injection is about 10 to 12 seconds, in which you will be able to evaluate the choroidal circulation. If there is a delay, that means that there is choroidal ischemia. After this, the dye enters the retinal vessels. There is a rapid filling of retinal arteries, and this phase is called as the arterial phase. There, it detects the arterial occlusion or narrowing. After that, capillaries start filling up, and then veins start to show the laminar filling. So then we have the arteriovenous phase just after the arterial phase. And in this phase, we recognize very prominent signs that we see in diabetic retinopathy, like microaneurysms or capillary dropouts or ischemia. Followed by the arteriovenous phase, we have the venous phase, which we see at 15 to 25 seconds after the dye injection, in which the full vein has now started to fill up, and both the arteries and veins are fluorescent. So this will help us to assess venous filling or leakage from the veins, or if there is any vascular tortuosity. And after that, we have the late phase, which is about 5 to 10 minutes after the dye injection. And now the dye starts fading from the vessels. There is persistent staining or leakage, and this highlights the neovascularization. So here I'm showing you a few pictures. Here we can see small leaks in the macular area in a very typical petaloid pattern. This petaloid leakage is suggestive of cystoid macular edema, which is commonly seen after a complicated cataract surgery when there is a breach of the blood-retinal barrier. In the second image, we can see pooling of the dye here, which is because of a serous pigment epithelial detachment. Now, always remember, we can never pinpoint a pathology with just one test. So the clinical picture, the fundus photograph, the fundus fluorescein angiography, and the OCT all have to correlate for you to be able to label a patient correctly with the correct diagnosis. Then here we can see blocked fluorescence. You see, we cannot see anything underneath these retinal blood vessels. There is blocking of the choroidal hyperfluorescence from the subretinal blood. So if there is a bleed, it will block what is behind it. So we will not be able to see that. And in this beautiful picture, you can see these small white punctate bright spots. There is a leakage that is happening. And then this all black area, this is the capillary non-perfused area. So there is large dropout of capillaries in this area. And this is seen in advanced diabetic retinopathy. So the question that you can get related to FFA is, which of the following is a common early phase observed in FFA? Venous filling, arterial phase, choroidal flush, or late leakage. Now, we have discussed the phases, and we know it enters the choroid first, the choroidal flush, followed by the arterial phase, then the venous phase, and then the late leakage. So if it was fastest fingered first in the correct order for KBC, the correct answer would have been CBAD, choroidal flush, arterial phase, venous filling phase, and late leakage phase. The next question is, which of the following is a contraindication to fundus photography? Now, in fundus photography, we are trying to click a picture of the retina. So the light has to be able to pass through the cornea, the pupil, the lens, the vitreous to be able to capture the retina. So if there is a severe corneal opacity, how will you be able to assess what is happening behind that corneal opacity? So a corneal opacity is a contraindication to getting a good fundus photograph. It's important to have a dilated pupil so that you can assess quite a few degrees of the retina. It's also important to assess in high myopes because high myopes are the ones likely to have a myopic CNVM or lacquer cracks or other degenerative changes. Cataract, in early stages of cataract too, we can easily click a fundus photograph. It's only in the advanced cataract that you cannot. But definitely with such a large corneal opacity, the light will not be able to enter and you will not be able to click a photograph. Now, I talked about another important element of visual function, that is the visual field. So to assess how many degrees of visual field have been damaged by a disease, we use a test which is called as perimetry. So the common test that is used is the standard automated perimetry using an automated perimeter. The most commonly used perimeter is the Humphrey perimeter. And here you can see a patient sitting with their chin resting on the chin rest and seeing through a lens. And they have to press the button when they see a flicker of a light or stimuli in the background bone. So there are fixed points of light which are shown at different intensity levels. The software automatically varies the intensity of these points of lights at each location to determine a certain threshold, the intensity of the light where the patient can see it 50% of the time. And that's how the printout looks like. This is very important for us to explain to the patient. You get a blind spot. This is the fixation where there is macula. And you tell that this all black area is the dead area. And, we want to save the rest of the area. So it's important for the patient to get treated and follow based upon these tests. So there are several types of perimetry. One is static perimetry, which is used for glaucoma diagnosis and progression. So the Humphrey test that we have seen in the previous slide is a static perimeter, where stimuli of varying brightness are presented at the fixed locations. On the other hand, kinetic perimetry, in this there is a moving stimulus which is brought from the non-seeing area to the seeing area. And then once the patient says, okay, now I can see it, the machine or the operator who is doing the test will mark that as a point. And when you have several points, these points are joined together to form a circle, and these circles are called as isopters. So isopters are characteristic of kinetic perimetry. And kinetic perimetry essentially is very important for mapping peripheral visual field effects. So the standard kinetic perimeter is a Goldman perimeter, but now newer models of octopus are also able to perform kinetic perimetry. And then when we have a patient in the emergency, or you are doing a bedside test to see whether a patient can see a particular part of a visual field, we do a confrontation test. So we close one eye and the patient also closes one eye, and then you show them a stimulus in each of the quadrants and see whether you can see them. So if they can see them, it is said that it is visible. If they cannot, then that quadrant is marked as black. So this gives you a vague idea that, there is something going wrong with the visual field and you need to do neuroimaging for such a patient. So essentially, it's a screening test done at the bedside. Then you have some other versions of visual field testing, which is the frequency doubling test. It is used for early glaucoma detection. We have a microperimetry, which is used for macular testing or the central visual field testing. We have the short wavelength automated perimeter or SWAP, which uses blue stimuli on yellow background, and it is used for the early glaucoma detection. Apna sandwich bana dena. Then we have multifocal VEP, which is used for functional assessment of visual pathway. Now, this is the most advanced version to test the electrical activity in response to visual stimuli over multiple locations. Now, we talked about fundus photography, we talked about fundus fluorescein angiography, and we talked about perimetry. So essentially, we are looking at different disorders of optic nerve head and the retina. It is very important to see various layers of retina to be able to pinpoint that which layer is responsible for a particular presentation of the retinal clinical picture. So OCT is the best tool that we have. It's a non-contact, high-resolution in vivo imaging modality. It's pretty much like the CT scan for an eye. I mean, it just dissects the retina into several layers, and you get to see cross-sectional tomographic images. Here are some of the images. This is how a normal retinal layer would look like. This is choroid, and this is the retina. These are the different layers which have been marked. This is a very typical cystic appearance in the foveal area. This is called as a foveal dip. And if there are lots of cysts and edema in the foveal area, which you can see in a diabetic macular edema. It helps you to tell whether this patient would require an anti-VEGF injection or some other form of therapy to get rid of this. Similarly, as we had seen in an earlier case, you can have a central serous retinopathy with adjoining neurosensory retinal detachment. So all these various retinal disorders can be picked up using the OCT. OCT is also used for glaucoma and for assessment of the retinal nerve fiber layer thickness. So here we have the optic nerve head, and the entire retinal nerve fiber thickness is divided into quadrants or clock hours, and we can see the average retinal nerve fiber layer thickness. And once it starts deteriorating as the disease progresses, we can step up our treatment to halt the disease at a certain point. There is another type of OCT which is called as the anterior segment OCT, and it helps you to ascertain if the angles of a patient's eye are open or closed. So here, as you can see, that the iris is pushed up and the anterior chamber angle is practically closed. So for such patients who are not cooperative for another test, which is the gonioscopy, ASOCT can help you solve certain dilemmas, whether to take them up for an iridotomy or whether to take them up for a cataract surgery. So an anterior segment OCT will tell you about the angle, will tell you a little bit about the cornea, will tell you about how high the lens vault is, and the posterior segment OCT will tell you about the retinal nerve fiber layer thickness when we are talking about glaucoma. So sometimes there can be a question about the principle behind this OCT test. So the options are fluorescein emission. Now we know that fluorescein emission is important for fundus fluorescein angiography and not for OCT. Sound wave reflection. Sound waves are important for ultrasound, not for OCT. Light wave interference and X-ray absorption. So the correct answer is light wave interference. The X-ray absorption would be used for an X-ray. So the first was for FFA, the second one was for ultrasound. The correct answer, light wave interference, is for an OCT, and X-ray absorption is for X-rays. Which layer of the retina appears as a highly reflective band on OCT? So these red bands are the highly refractive bands. So the retinal pigment epithelium, this broad red layer that you can see, is the most highly reflective band on OCT. So the correct answer out of these is answer B. So RPE, or the retinal pigment epithelium, is the highly reflective and it appears red on an OCT. Going a step further, combining OCT and fundus fluorescein angiography. Now, in fundus fluorescein angiography, there is an injection being given in the antecubital vein. A fluorescein dye is being injected, and in many patients, this fluorescein dye can cause allergic reactions. So now, when we fuse the two techniques, we have a very advanced technique called as the OCT angiography, which tells you about the microvasculature of the retina and choroid in a non-invasive manner without the use of a dye. So that's OCT angiography. Coming to ultrasound, there are two types of ultrasounds that modes that can be used. One is the A scan. It's an amplitude scan. It tells you the character and size of a lesion, and each tissue in the body will have a separate reflection pattern. So here, A scan is done usually for biometry in those areas where a sophisticated biometer like an optical coherence biometer is not available, or in patients who have a mature or a hypermature cataract, this comes in handy. So there are 5 spikes that are produced, and the first spike is that of the cornea. The second spike that is produced is of the anterior lens surface. The third spike is of the posterior lens surface. The fourth spike is of the retinal surface, and the fifth spike is the orbital spike. So an ultrasound A scan is used for biometry. You can get a question on what is the normal axial length of an adult eye. There can be several options, but the correct answer to that would be 22 to 24 millimeters. Myopes have a longer axial length, hypermetropes have a shorter axial length. Then, when we have a mature cataract, or when we have a corneal opacity, as we saw in the case where, we were not able to do a fundus photograph, or when we have a vitreous hemorrhage, then how do we see what is happening in the retina? How do I know that there is no foreign body, or there is no retinal detachment, or there is no retinal tumor? Then this B scan mode of the ultrasound machine comes in handy, as it tells us about the topography of the lesions. So there is an echo, which is represented as a dot rather than as a spike in B scan. So we were seeing dots on an A scan, and we see spikes on a B scan. The brightness of the spot represents the reflectivity. If there are no spikes as an aqueous or vitreous, you will get a black echo. As you see, if there is nothing in the vitreous, it will be black. The largest amplitude or the greatest brightness is presented as white. So the lens with the cataract will appear white. This section of the tissue is examined by a sound beam that slices through that section. So we can have a longitudinal section or a transverse section depending upon the area of interest. So here we are able to pick up pathologies like retinal detachment. This is a retina that is detached, or you can have a tumor which is coming from the choroid, mushrooming out of it, a typical mushroom sign, that's the choroidal melanoma, or you can have an intraocular foreign body in the vitreous cavity. So you can get a question like the B in B scan stands for binary, biometric, brightness, or background. As I've already mentioned, B scan stands for a brightness scan, and A scan stands for an amplitude scan. Which frequency of ultrasound is typically used in an ocular B scan? 1 to 2 megahertz, 5 to 10, 20 to 50, and 100 megahertz. The correct answer is about 7.5 to 10 megahertz. Now, if I want to go deeper, and if I want to look at the ciliary body, or if I want to look for choroidal detachment or more choroid or the ciliary processes, then I will require about 35 to 50 megahertz of a probe. But otherwise, for a routine B scan, we need about 7.5 to 10 megahertz. So the correct answer here is B. Then comes keratometry. Now, this keratometry is used when we want to measure the curvature of the anterior surface of the cornea, especially the central 3 meters. So we can either have a manual keratometer, the most commonly one used at most places is the Bosch-Lomb type, or we can have an automated keratometer. Now, here I would want to take your attention to 2 more similar devices, but they measure something different. Corneal topography measures the full corneal mapping. It will map the entire surface of the cornea, the anterior surface, the posterior surface, the central and the pericentral area, and tell you about the thickness and the curvature at each of these points. Pachymetry talks about the corneal thickness. So if I'm talking about thin cornea, thick cornea in context of glaucoma, then I'm talking about pachymetry. If I'm talking about a disease like keratoconus, where I want to see whether there is central thinning or peripheral thinning, I will be doing topography. But if I want to calculate the power of an intraocular lens, then I can just go ahead and do a simple keratometry. So this is how a manual keratometer looks like. This is a Javelin, the Bosch-Lomb type. And, depending upon the type of the astigmatism, you will get different sort of circles inside it. It's used for contact lens fitting, preoperative assessment of cataract surgery, diagnosing corneal disorders like irregular astigmatism, keratoconus. The automated types of keratometer are used for refractive surgery planning. For you, it is important to remember some normal keratometric values. The average corneal curvature is around 43 diopters. The normal range is about 41 to 45, 2 diopters on either side. Flat cornea is less than 41 diopters, and steep cornea is more than 45 diopters. When we talk of advanced corneal imaging, as I already mentioned, topography does anterior curvature mapping. Tomography does 3D anterior and posterior mapping. The anterior segment OCT that I had already shown you for the angles also gives you high resolution cross-sectional images. So you can see different layers of the cornea. You can see the angle, the anterior segment. Specular microscopy helps you assess the endothelial cells or the endothelial layer of the cornea. So if the endothelial cells are not healthy, and if you plan to do a cataract surgery or any surgical procedure, the outcome can be guarded. So it's important to do pre-op screening. And if you're using a corneal graft for a patient who has an opacity, for corneal graft follow-up also, it's important to do a specular microscopy. If you want to go more in details of different types of cells of the cornea, then you can do a confocal microscope. So the question can be, the standard keratometry readings are taken at which zone of the cornea? Central 1 meter, paracentral 3 to 4, peripheral 8 millimeters of the entire cornea. Now, I mentioned in the first slide, when I talked of keratometry, the standard area is 3 or 3.4 millimeters, depending upon the device that we are using. So we are here talking about paracentral 3 to 4 millimeters. Now we are advancing in different types of technology. Now, in a basic setup, if I want to calculate the power of an intraocular lens, I can just use an A-scan to measure the exit length, and I can use a simple manual keratometer to get K1, K2, and then in the A-scan, I can put in these values and take out the power of the lens. But now, the cataract surgery is a state-of-art affair. You want to give the precise correction to your patient. Therefore, it is important for you to know a lot of parameters. And for that, we have a sophisticated device, which is called as the optical coherence biometer, involving the similar concepts of an OCT. And here, the parameters that are considered include, in addition to exit length and keratometry, anterior chamber depth, the lens thickness, the wide to wide distance, and the central corneal thickness all together to give you a correct power. So there are two main devices that are being using this technology. One is the IOL Master, and then we have the Lens Star. Let's not go into details of this, but it is important for you just to know that optical coherence biometer takes care of multiple parameters to give you a precise biometry for newer and advanced intraocular lenses. There are different formulas for different scenarios, and once all these formulas are fed in, this optical coherence biometer will give you this sort of a printout, and you can figure out, you want to use a toric lens or a multifocal lens. For different lenses also different, there are A constants, and once you feed that, you get different type of IOLs, but I'll not go in details for that because that's a little bit advanced for you. So the question that can come is, optical biometry uses which principle to measure exit length? Ultrasonography, optical interferometry, polarized light microscopy, or fluorescein imaging. Now here, it is the principle of optical interferometry because it is going through several different media, from cornea to aqueous to the lens, and then to the vitreous, and eventually, taking out the exit length. Therefore, the concept that is being used here is optical interferometry. Optical biometry can provide all the following parameters except exit length, yes, of course, central corneal thickness, yes, anterior chamber depth, yes, retinal nerve fiber layer thickness, no, because that we get to know by OCT. You have to remember the difference between OCB and OCT. So with this, we come to the end of this elaborate topic, and I wish you all the very best for your preparation. And if you have any questions, I'm open for discussion. You can just shoot your queries on my email account if we are not able to take them now. I'm happy to help you with any other queries also. You can just drop in your email to me, and I look forward to questions in the inbox.